Hey everybody, this is Alex. I am in the pathologist assistant program at Tulane, and today I'm going to go over a case that I wanted to present for my case report, and it is tongue lesion proven to be squamous cell carcinoma. And this patient was interesting to me because he didn't really have any risk factors for developing this really ulcerative and invasive carcinoma. So I just thought it was an interesting case to highlight and to bring our attention to, that you don't always have to be um, a heavy smoker, drinker, or some of the other risk factors that we'll talk about in order to develop these type of cancers. So it's important to be to have it on your radar, to check in your mouth, to check under your tongue, to check all around the oral cavity for things like this. So the patient was a 54-year-old male with a non-healing ulcer for 2 months. He had a history of mouth ulcers, but he presented to clinic with pain on the left side of his tongue and acute distress. He had a myocardial infarction 2 years prior, was on Plavix. And during his ENT exam in the office, it showed a left lateral tongue lesion, 1.4 centimeters, that was ulcerated. He has a past medical history of hypertension, Barrett's esophagus, diverticulosis, and diverticulitis, depression, sleep apnea, a septal defect, myositis, and myalgia. So the patient underwent a biopsy right there in clinic, and it showed a well to moderately differentiated squamous cell carcinoma. He then went on to have some imaging. They sent him for a PET CT scan, which showed a hypermetabolic uptake at the left base of the tongue, consistent with this history of neoplasm that they saw in clinic. There was also a low level uptake in the left cervical and supraclavicular lymph nodes. He also had a mild asymmetric uptake in the left posterior nasopharynx region. Without a discrete lesion seen, they recommended to clinically correlate this with a direct visualization of that area. And there was a little bit of a left uptake in the soft palate. So you can see where I circled this just enhancing lesional area on the left side of the face. And again, here it's more of like that posterior aspect of the oral cavity. So this is a specimen that I received, and I have it kind of flipped on its side so that you can appreciate the ulcerative area here. But according to the stitch markings, the short stitch is anterior. So like, that was like the most anterior part of the tongue. And then the long stitch was the dorsal portion of the tongue. And the dorsal part of the tongue is like the top part of the tongue. Think of like a dorsal fin on like a dolphin. So it's like that top, like velvety, roughened area of your tongue that, when you stick your tongue out and you say, ah. So that's what this part is. And then the lesion was like on the side. So I just have the area like flipped down. And I differentially inked it into different colors. You can't see all of the colors here on the serial sections, but, inked anterior surface one side, posterior surface one side, the medial and lateral surfaces in deep, all different colors. And so the specimen also came with a neck dissection from levels 1, 2, 3, and 4, as well as a submandibular gland. And if you're not familiar with this type of neck dissection, it's usually like in a Z-shaped configuration, which may be hard to appreciate, but just think of it as like it's zigzagging like across, down as a diagonal, and then over. So you typically separate this off into levels 1, 2, 3, and 4. And also like separating your submandibular gland off and sectioning through that as well. So on the photomicrographs, down here, we have an invasive component with acute inflammatory infiltration that is reacting around the cancer. So they can tell that this is a squamous carcinoma because you have this transition from normal squamous epithelium into this invasive component. And another hallmark of squamous cell is these keratin pearls, which are these nice pretty pearls here. They have some eosinophilia to them. So final diagnosis, which because this patient already had a biopsy, they kind of knew what they were already working with, but an invasive, well-differentiated, and keratinizing squamous cell carcinoma. The lesion was 2.6 centimeters in greatest dimension with a depth of invasion of 0.8 centimeters. The margins were negative for malignancy, which is great. And it was also negative for perineural and lymphovascular invasion. So into etiology and epidemiology, oral cancer is the 8th most common cancer worldwide. It affects males 2.5 times more than females, and there's an increased prevalence in South Asian countries. Oral squamous cell carcinoma is actually the most common cancer in India. It has a 50% mortality rate in 5 years. And that is for, I don't know why I wrote that here, HPV negative squamous cell carcinoma. Okay. Also, smoking tobacco, chewing tobacco, and drinking alcohol are the biggest social risk factors, which are preventable risk factors because, that's something that you can make lifestyle choices and change. However, the biggest viral risk factor, which is also preventable, is the human papillomavirus. And I say it's preventable just because you can get your children vaccinated at, I believe, the age of like 9 or 10, up until the age of like 30 now. You can get an HPV vaccine, and the vaccine started off with just protecting against some of the most like common strains of HPV that causes cervical and oropharyngeal cancers. But now the vaccines they cover so many more different HPV strains than just 16 and 18. You can also have chronic oral inflammation from either like a leukoplakia or an erythroplakia, which can develop into a squamous cell carcinoma, which may have been what happened with this patient. Another option is poor diet habits, which I never really thought about as a risk factor to developing oral cancer, but there's actually a lot of research articles on it. So poor diet habits, poor dental habits, and also immune dysfunctions can have a role in oral squamous cell carcinoma. But up to 20% of cases just have like an unknown etiology. It just arises. So the pathogenesis, you could have genetic alterations in chromosome 9p21. You can have epigenetic changes like a p53 mutation, which is like a tumor suppressor gene. You can have exposures to carcinogens, and some of those things that I mentioned before. There's a lot of carcinogens in tobacco and smoking use, either like by chewing tobacco or actually like smoking tobacco. And then there's exposure to HPV viral particles, which can transform healthy tissue into cancerous lesions. All of this basically from inactivation of tumor suppressor genes, activation of oncogenes, and then again, you can have leukoplakia and erythroplakias, which can transform into malignant counterparts. So morphologically, a leukoplakia will have areas of hyperkeratosis, which lead to epithelial thickening and then can potentially turn into dysplasia. Leukoplakias are like these little like white deposits on the tongue, which they won't like scrape off if you try to scrape them off. Whereas a erythroplakia is still going to have the same morphologic features as the leukoplakia, but it has an 80 to 90% chance of dysplastic transformation. And an erythroplakia, is just like what its name sounds like, erythro. So it's like this red kind of like lesional area on the mucosa. So once you have mild to moderate oral epithelial dysplasia, you'll see nuclear hypochromaticity, and you'll see the little reedy ridges. They'll like drop down in a third of the epithelium. Once you get into severe oral epithelial dysplasia, you have loss of cellular organization, and then you have these bulbous reedy ridges in about 2/3 of the epithelium. And then once we kind of transition over into carcinoma in situ, these dysplastic cells now fill the entire thickness of the epithelium. And then finally, that true transformation to a carcinoma the tumor cells then break through the basement membrane with variable atypical mitotic features. So clinical pathologic correlations, again, for this patient, there was no alcohol, no smoking, no chewing tobacco, no HPV infection history. He did have poor diet and exercise habits. He also had a very high BMI. He had this oral ulcer history, not just the ulcer that he had for the past 2 months, but he had a clinical history of like chronic oral ulcers. And then he had comorbidities such as hypertension, a heart attack recently, and also Barrett's esophagus. So, outcomes for him, he did have negative surgical margins. He did have negative lymph node involvement, which is great, but he had a non HPV associated squamous cell carcinoma, which has a higher recurrence risk. And I think that's what I was trying to say in that other slide that I was confused about the wording. So, if you have a non-HPV associated squamous cell carcinoma, the mortality and morbidity is a lot higher than if you have an HPV associated squamous cell carcinoma. Patients who have these HPV associated squamous cell carcinomas, even though they have a carcinoma, the HPV has some type of like protective effect on like the, I guess the, like just how bad it is and how like much it'll metastasize into like lymph nodes and stuff. So they just find that HPV associated squamous cell carcinomas are like almost better to have. I don't really think any cancer is better to have, but by the research and the data, that is supposedly like what they say. So for him, it was not HPV associated. I actually asked for HPV testing on the block because that was my next thought after I saw that he had no smoking history, he had no alcohol history. He, like he was not like a very old, like to me, he's in his 50s. So he's not like really, really old. And so I was like, oh, he must have HPV. Like that would make sense, why he has this like really funky, like ulcerating tongue lesion. And then the HPV test came back negative. So then I was like, all right, well, how do you get this like really bad ulcerating lesion on your tongue without all these risk factors? So it could just be, like I said, poor diet habits, poor dental habits. It could be just this history of chronic ulcers. It could be a dysplastic leukoplakia or erythroplakia that perhaps he never saw, and it just transformed into this dysplastic into from dysplastic into a carcinoma. So again, clinical features, these are just things that you should look out for in anticipation of squamous cell carcinoma of the tongue. So any thickened areas in the oral cavity would raise a red flag. Oral ulcers, if they're like coming and going and not like fully healing or not going away for like a prolonged time. Pain in the mouth, dry mouth, any difficulty moving the tongue, that could mean there's some like restrictive lesion back there that you can't even see like way in the posterior or like underneath the tongue. Persistent bad breath, weight loss, this could, potentially mean metastases, difficulty swallowing or chewing, and then any loose teeth or sore jaw, that could potentially mean like metastases into the like mandible or maxilla from like a direct extension, perhaps, if not a metastases. So treatment and prognosis, typically you want to go ahead and just resect that tumor out. It's the first choice of treatment, although it is a very invasive procedure. If you think about it, having to remove anything in the oral cavity is just a very, very, it's a very traumatic surgery. So these patients have to go through a lot of speech therapy and different type of therapies to learn how to get a lot of their facial movement, swallowing, talking functions back. Poorly differentiated tumors or advanced stage patients could need additional radiation or chemotherapy regimens. Unfortunately, for this type of cancer, over 50% of patients do relapse despite this aggressive treatment. So there's a lot that can be done to raise these, success rates of complete remission. There's targeted VEGF treatment. It's a way to stop tumor angiogenesis and metastases through lymph nodes. And there's also kind of like this new way of detecting oral cancers by using saliva. So, saliva is the kind of closest biofluid to the tumor. And so, why not see if there are biomarkers in the saliva, especially for countries or for underserved patients and for countries that don't have access to, fancy PET scans. How easy is it to spit in a tube and be able to put the saliva on a detection kit that would be able to tell you if there is potential malignant cells in the saliva sample? It's kind of similar to like those stool samples that you can do in clinic. So a lot of people really don't want to get a colonoscopy. Who wants to go get a colonoscopy? So now you could take these little like test kits home with you and you like put your poop on a stick and it'll literally tell you like if you potentially have colon cancer. So it's the same idea, but with saliva and with oral cancer. And these are my references, and that's all I have. Thanks, guys.